I'm Victoria Emerton, and welcome to Behind the Design, brought to you by Design in Mental Health, the leading in-person event connecting professionals from around the world who design, create, manage, and deliver care in the built environment for mental health care. Design in Mental Health takes place in the UK each June and features a comprehensive programme of presentations, panels, and workshops, a free-to-attend exhibition of specialist products and services, and the prestigious Design in Mental Health Awards. The event website has all the information on the event dates, the programme details, and how to book your event passes. Today, I'm delighted to be joined by Virginia Pankey, Behavioural Health Practice Leader at HOK. Virginia, welcome to Behind the Design, and thank you very much for your time today.
Thanks for having me. I appreciate it.
So you're going to be presenting with Dr. Marsha Whittink, who's a practicing physician and associate professor at the University of Rochester Medical Center. And the presentation you will both be delivering is pioneering the design and function of Medical-Psychiatry Units, MPUs, bridging acute medical and mental health for whole person care. And that's what we're going to be talking about today. So can you share how MPUs have come into being in terms of balancing medical accessibility with psychiatric safety requirements?
Sure. I'd love to talk about these units. The evolution of the Med-Psych unit represents a significant advancement in how we approach the integrated care. Historically, we've operated a divided system, medical surgical units on one hand and psychiatric units on the other. The separation creates a fundamental challenge in providing comprehensive care. What we've come to understand through both research and clinical experience is that patients with severe mental illness are approximately 20% more likely to have concurrent medical issues than the general population. These diagnoses don't exist in isolation. They coexist within one person who needs a holistic treatment. Consider a patient with schizophrenia who has a poorly controlled diabetes. In traditional inpatient setting, this patient would typically require one-on-one supervision to ensure safety. This approach is not only extremely resource intensive and expensive, but it also places tremendous strain on clinical staff who often lack specialized training in psychiatric care. This creates a challenging dynamic where staff may feel unsafe, patients feel their needs are being dismissed, and the healing environment for everyone on the unit becomes disrupted. MPUs were developed specifically to address these challenges, creating integrated environments where both medical and psychiatric needs can be addressed simultaneously rather than sequentially. The physical space is deliberately designed differently, allowing for appropriate supervision while maintaining patient dignity. These units are staffed by professionals with cross-disciplinary training who can both manage medical procedures and employ de-escalation techniques when necessary. The result is a more efficient healing process where patients feel respected rather than marginalized. Rather than treating the psychiatric condition as an obstacle to medical care or vice versa, MPUs acknowledge that both aspects require equal attention and expertise. This integrated approach represents healthcare's growing recognition that separation between physical and mental health creates barriers to effective treatment. MPUs bridge the gap, providing a model of how we might better serve patients with complex, co-occurring conditions in a way that heals their whole person.
That sounds really interesting and sort of surprising if that hasn't been addressed before, actually. So can you describe specific therapeutic design elements that have proven most effective in creating healing spaces and that address both psychiatric and medical needs? How does it work in practice?
Designing effective med-psych units, we've had to challenge some functional assumptions about inpatient care. A common misconception is that these units primarily serve patients with acute medical conditions who are bedbound. In reality, mobility is crucially important to this patient population. Many patients with psychiatric conditions have developed their own methods of self-regulation, which often involves movement. These might be walking patterns, physical routines, or simply the need to change environments periodically. Restricting this movement can exacerbate psychiatric symptoms and impede recovery. Therefore, one of the most important therapeutic design elements is creating adequate space for ambulation, corridors, and areas that allow for safe movement while maintaining appropriate supervision. Beyond individual movement, these units require thoughtfully designed common spaces that serve multiple functions. Group therapy areas and activity spaces are essential components that traditional hospital units simply don't accommodate. Standard medical unit designs optimized for bedbound patients and clinical efficiency typically lack these vitally therapeutic environments. Another critical design consideration is the adaptability of physical space. The spectrum of mental health issues that can co-occur with medical conditions is extraordinarily broad, from severe depression to schizophrenia to eating disorders. This variation demands flexibility in how the spaces can be configured and utilized. For instance, a patient with eating disorder requiring IV or tube feeding has dramatically different clinical interventions and privacy needs compared to someone managing both bipolar and diabetes. The bed design itself represents a fascinating example of therapeutic integration. These specialized, unique beds that can be positioned at appropriate heights for medical procedures while also meeting psychiatric safety requirements. They need to accommodate medical equipment without introducing ligature risk or other safety hazards common in the standard hospital beds. The most successful MPU designs incorporate natural light, reduced noise, and clear sightlines for staff supervision without creating an institutional feel. Color and artwork play a role as well, choosing palettes that promote calming while avoiding institutional colors that can feel depressing or clinical. Ultimately, the effective therapeutic design for MPUs creates environments where both the psychiatric and medical needs of patients can be addressed without one compromising the other. This integration represents a significant advancement in how we conceptualize healing spaces for complex patient populations.
There's a lot of plates spinning there, aren't there, for sure. So talking to people with lived experiences is really important. And at Design in Mental Health, we place a lot of emphasis on that throughout the event. So how has input from peer support specialists with lived experience and patient priorities research influenced your planning approach to designing MPUs?
Victoria, you are so correct. The evolution of our approach to designing medical psychiatric units has been profoundly shaped by the inclusion of peer support specialists with lived experience. This shift represents a fundamental change in how we conceptualize these spaces, moving from a purely clinical perspective on to one that honors the full humanity of the people we serve. One of our most transformative initiatives was the Reimagining Workshop, which brought together a diverse group of stakeholders, including clinicians that practiced in this area, healthcare architects, and crucially, individuals with lived experience of both medical and psychiatric hospitalization. Though through both virtual and in-person discussions, we created a forum where the expertise of experience carried equal weight to clinical and architectural expertise. What emerged through these conversations was often a stark contrast between how designers and clinicians envision these spaces versus the priority of those who actually inhabit them. Designers and medical professionals frequently approach the planning process with preconceived notions about what a medical surgical unit should look like, with primary focus on staff efficiency and clinical safety. While these factors remain important, the peer support perspective introduced a critical counterbalance. Individuals with lived experience shared powerful insights on how certain hardened safety elements, while clinically justified, sent deeply problematic messages about their worth and recovery potential. They described the psychological impact of entering a space that immediately identifies them as other or dangerous through visible safety features and restrictions. These environmental cues can actually exacerbate feelings of shame, hopelessness, and alienation, precisely the opposite of what promotes healing. What these peer specialists emphasized repeatedly was their desire for normalcy and dignity. Their priorities were alarmingly simple. I want to watch TV. I want to walk down the hall, get a cup of coffee. They acknowledged the necessity of medication and certain safety measures, but firmly rejected the environments that felt like they were physically restrained, even if that was just an emotional reaction. This input has fundamentally altered our design approach. We now prioritize creating spaces that feel accepting and normal, while discreetly incorporating necessary safety features. Peer specialists have helped us understand that the psychological impact of the environment is not a luxury consideration, but a crucial component of effective treatment.
So there's what you'd like to do, and I guess there's what you're allowed to do. So navigating regulatory compliance could pose a challenge in these hybrid spaces. Can you explain how addressing the complexities of meeting behavioural health safety standards while ensuring that spaces remain conducive to medical treatment? How do you manage to keep both elements working?
You're very correct. It's a challenge. The regulatory landscape of med-psych units in the US presents unique challenges precisely because these spaces exist at the intersection of two healthcare domains with different and sometimes conflicting safety standards and requirements. One of the most significant regulatory complexities we face involves cross-training staff to meet the diverse needs of this patient population. In many regions, there simply isn't specialized care available for certain conditions. For example, a patient with an eating disorder may require an IV or a feeding tube procedures that psychiatric nurses typically do not perform. Regulatory bodies often have separate credentialing and staffing requirements for medical versus psychiatric units, which creates bureaucratic hurdles when developing truly integrated teams. From a physical design perspective, the regulatory challenges are equally complex. Take something as seemingly straightforward as a fire alarm pull station. Behavioral health regulations might dictate that these should be inaccessible to patients to prevent false alarms, while medical facility codes require them to be readily accessible in emergencies. Ligature-resistant products represent perhaps the most obvious example of regulatory complexity. These specialized fixtures, from door hardwares to shower controls, are mandatory in psychiatric settings, but may complicate medical delivery. For instance, ligature-resistant handrails may not accommodate ADA requirements for a standard patient mobility needs. Finding products that satisfy both sets of requirements often involves seeking regulatory variances or developing custom solutions. What's particularly challenging is that the regulatory guidelines for these hybrid spaces are still evolving. While foundations are being created that can translate across jurisdictions, designers and administrators, clinicians also, might often work directly with authorities having jurisdiction to develop acceptable compromises. This process requires extensive documentation and justification of how specific design choices balance competing priorities. The most successful MPU projects approach regulatory compliance not as a checklist exercise, but as an opportunity to rethink how spaces can simultaneously meet seemingly contradictory requirements. By focusing first on patient outcomes and working backward to design solutions, we've been able to create environments that satisfy regulatory bodies while still providing therapeutic benefits for this unique patient population.
Well, hopefully you're going to share some of those magic navigation pathways that you seem to have discovered with people coming to the event. So looking towards the future of MPU design, what innovations or trends do you see emerging that might transform how these specialised units function? And is that something that you and Dr. Whitting are going to showcase at the conference?
Absolutely. The Medical-Psych Consortium has developed operational guidelines for med-psych units. We will discuss the overlap and differences between these and the environmental guidelines for this unit type. We'll look at data from Dr. Wittick's specific unit in comparison to typical med-surg unit data. Things such as the patient length of stay. Patients coming back is less likely to occur when you've had this specialized unit and have the right staff members to help connect patients with outpatient services along the continuum of care that they will need after they've been discharged from the hospital. Staff retention and percentage of staff with experience of this patient type is also important. In the US, the reimbursables need to get caught up with where the care is. Currently, most choose alignment with whether you start as a primary establishment of a medical or a psychiatric diagnosis, which is really a big hurdle to overcome. Financial impact of these patients with coexisting conditions, future welcoming, build the environment so regulators can see the data related to the cost and time savings to get a patient the combination of care that they really need at one time.
It sounds like there's a lot more to discuss, which is the beauty of events, that you're going to be there with Marcia and have time to engage and talk to people. So we're really looking forward to having you come and present at the event. So you're going to be speaking on the 3rd and 4th of June. Design and Mental Health takes place on those dates in Manchester. Anybody watching this, if you'd like to engage with Virginia and Marcia, do come along and have a chat, come to the presentation. And that's what events are all about. In-person events is talking to people, sharing experience, and getting those nuggets of information that you wouldn't get any other way. So I've really enjoyed this conversation. Thank you so much for your time today. We look forward to seeing you in Manchester in June. Safe travels coming over to see us. And we'll see you very soon at Design and Mental Health. Thank you very much for your time today.
Thank you so much. And I really look forward to the discussion in Manchester.
Fantastic. Thank you.